trying to figure out here.
It's okay. We're recording now, so whenever you're ready, we'll have time.
Okay, can you guys see it?
Yep.
Yes.
Stephanie, did you say no?
No, I see it. I got it.
Okay. Okay, great. And I'm gonna stand up and do it. Can you guys can't see me though, right?
No.
Okay. Okay. So I guess Julie, you can go ahead and start the timer.
Okay.
The title of my project is Increasing Effective Care of HIV, Hepatitis B, and Hepatitis C in Syringe Exchange Participants at a Public Health Department. This is a picture of me in front of my bulletin board with infographics regarding testing information on HIV, Hepatitis B, and Hepatitis C. We used those infographics as pull sheets for our shared decision-making tool. Some things that you should know: approximately 10% of people with HIV/AIDS are people who inject drugs. The estimated lifetime HIV/AIDS treatment cost per person in the United States is just under $400,000. Hepatitis C virus increased 3.5-fold in the United States from 2010 to 2016. Hepatitis B virus causes 3,000 deaths annually in the United States and costs $360 million. A chart audit showed that SEP participants were not being regularly tested for HIV and hepatitis in our health department. There were no patient engagement strategies within the SEP program, and there were no right care procedures for seropositive SCP participants. Team engagement was only 50%. So what do we know? We know that studies show SCPs are often the only source of primary care for people that inject drugs, but most programs don't offer basic recommended preventative health services. Evidence also shows that HIV, hepatitis B, and hepatitis C testing should be performed periodically on all people who inject drugs. Best practice guidelines dictate that HIV, hepatitis B, and hepatitis C educational materials, testing services, and referrals to treatment for seropositive participants should be standard practice. Studies show that simultaneous point-of-care testing for HIV, HBV, and HCV improve patient outcomes and linkage to care. This project uses screening, brief intervention, and referral to treatment model for QI. The Institute of Medicine's aim used for this project was to provide effective care to SEP participants. This project was modeled after the New York State Department of Public Health AIDS Institute policies and procedures for SEPs. The aim of the project was to increase testing and right care of HIV, hepatitis B, and hepatitis C in syringe exchange participants by 30% in 90 days. This project was implemented in the syringe exchange program at the Public Health Department in Frankfort, Kentucky. SEPs were legalized in Kentucky in 2015 after Senate Bill 192, dubbed the Heroin Bill, was signed into law by Governor Steve Brashear. My harm reduction team included 11 female health department staff members, including the director, Judy, the QI coordinator, and my sponsor, Brittany, 3 registered nurses, the director of nursing, Sally, 4 ancillary staff members, and 1 social worker. Patients included were 208 males and 159 females. 71% identified heroin as their drug of choice. This project was a rapid cycling quality improvement project that used 4 plan, do, study, act cycles lasting 2 weeks each. 4 core interventions were implemented and continually amended for improvement. The interventions used were weekly SEP QI meetings with an agenda for team engagement. We also used syringe exchange program champions and effective meeting guidelines. For patient engagement, we used the bulletin board that you saw on a previous slide with infographics that the patients could pull off and give to their provider to discuss testing, and then we evaluated the effectiveness of the bulletin board with a sure test. There was a one-page testing registration form developed that was amended continually to include state-required information on HIV and hepatitis C. There was the case management log that was developed to track right care for the participants. Right care meaning patient referral, patient notification, and appointment reminder cards given. To study the information, we collected data twice weekly. The data that was collected twice weekly were data collection sheets, testing registration documentation forms, sure tests, and CMLs. Team engagement surveys were collected weekly after each meeting. The surveys, the shared decision-making tool utilization, and right care elements were averaged. Data was evaluated using aggregate data collection sheets in Excel, and then they were converted into run charts to identify trends, shifts, and improvements related to the testing change. Each measure was defined with a process measure and an outcome measure. Team engagement was measured by the average score of the QI meeting agenda, and the average scores on Likert scales for surveys after the meetings that measured team engagement, including morale, communication, and organization. Patient engagement was measured with the shared decision-making tool utilization rate and the average score using a Likert scale of the sure test post-visit. The testing registration documentation form was measured with form utilization and the testing rates. There were two outcomes with the form. The first one was the testing rate of all eligible participants and the seropositivity rate. The case management log was measured with the utilization rate for seropositive patients and the average score on a right care scale. Our balancing measure was wait time for non-SCP patients from registration to exam. We didn't want increased testing and right care in the SCP program to negatively affect other patients in the health department, so that's why that measure was chosen. To analyze the quantitative data, we used the data that was placed in the Excel sheets and then converted those into run charts twice weekly. Qualitative data was assessed through verbal feedback at team meetings. Team themes regarding patterns in the data were used to drive test change, and the field notes were reviewed and discussed at weekly meetings. This project was used for review by the IRB at Frontier Nursing University. It does not qualify as human subjects research and meets federal requirements for quality improvement. There were no outside funding received. So our results. For team engagement, we increased the effectiveness of the agenda to 66% from 50% baseline. Team engagement increased from 50% baseline to 84%. The shared decision-making tool utilization increased to 22%, and the average score of the sure test, which measured the patient's confidence in their testing decision, increased from 0% to 84%. Form utilization for the testing registration documentation form was 100%. Every time a patient was tested, they used the form. The testing rate was 25% overall. And then after eligibility was established in cycle 2, we implemented eligibility screening, meaning that if the patient had been tested somewhere else in the past 6 months, they were excluded from the study. That increased our testing rate to 38% post-eligibility screening. Our seropositivity rate was 20% hepatitis C positive. The case management log utilization was 100%. Every positive result that we got, the patient was logged on the case management log and given right care when it was feasible. The average right care score was 45%. So patients were provided some element of the right care bundle 45% of the time. And this is really great. The balancing measure, which was the time from check-in to exam room for non-SEP patients, actually decreased by almost 3 minutes during our project, meaning that even though we increased testing, we increased right care, we increased team engagement, we increased all of it, our balancing measure actually decreased by 3 minutes. So there were no negative effects on any other health department patient. This is my first run chart. It shows the aim of the project, testing rate, and right care. You can see that on January 31st, that's when we implemented screening for testing eligibility. With you can see the market increase on February the 7th. And then also another sharp increase when we implemented appointment reminder cards for patients who were eligible for testing but declined testing on that visit. This is a rim chart of the testing rates. They were variable on a day-to-day basis, but overall, they increased to 25% overall and then 38% post-eligibility screening. Patient confidence in testing. This is the graph that represents the results that we got from our sure tests. As you can see, the first cycle, they were all linear. That's because the responses on the sure test were either yes or no. When we amended that in cycle 2 to include responses on a Likert scale, you can see that the variability increased. When the patients were tired of seeing the same infographics, we started rotating them and changing them, and then that led to an increase in patient confidence in testing because of the new material. This is the graph showing our weekly QI meeting evaluation surveys. The most market increase was from the baseline to January the 25th. Baseline was our kickoff meeting. January 25th was our cycle 1 meeting, and our first champion was elected. In cycle 3, we only had 1 meeting, but we had a very confident champion that increased our team engagement scores. So I implemented a one-on-one teaching session with the cycle 4 champion. Strengths of the project included generalizability, because the project only used simple interventions that were easily duplicated. And also, the project is very sustainable. We only used evidence-based printed educational materials that were easily found on the CDC's website, lab supplies for testing, and teamwork. Just good old-fashioned teamwork. In summary, our findings were that our overall testing rate and right care was 32%. That's an average of both. We exceeded our 30% goal of our aim. Patient engagement increased from 0% to 84%, and team engagement rose to 84% from the 50% baseline previously mentioned. So what does all this mean? The registration documentation form increased testing because it streamlined the whole process. They didn't have to have an inch-thick chart anymore for testing. They could do the registration and documentation all on one page. Staff really liked that. And it had a massive impact on testing. The shared decision-making tool increased patient confidence in testing and therefore testing rates. Patients were confident in their decision and they said, okay, this is great, let's get tested. The case management log led to seropositive patients being linked to right care 45% of the time, when before they weren't being referred to anyone if they were positive. Increased team engagement with small extrinsic rewards, and the champions who served as project liaisons, they were really the rock stars of this project, drove positive outcomes in every aspect of the process. Patient engagement, testing, right care, all of it. If it wasn't for the team, none of this would have happened. The literature tells us that team-based care improves patient outcomes, that simultaneous testing leads to improved health outcomes. And again, the SEPs are often the only access to preventative health services for people who inject drugs. So, based on what the literature says, we did all of those things, and it worked out great. This project provided the health department a streamlined and standardized process for providing HIV and hepatitis testing and right care to SCP participants. This process, the team can continue these meetings independently. The meetings were champion-led with no management required. 35 participants were tested and 7 HCV positive participants were identified, notified, and linked to care when applicable. Limitations of the project included staff shortages and time constraints because we are in public health. There's always staff shortages. We used a self-report data system for testing, but we found out that actually 64% of patients were taking an active role in their healthcare and being tested other places, and they were very honest about where and when they were tested. We dealt with a high-risk population of IV drug users, which led to its own set of limitations, and we mitigated all of these limitations by trying to streamline the testing process as much as possible to get everything done as quickly and easily as we could. In conclusion, decreasing the testing paperwork and standardizing the testing process was the most impactful intervention that we did, in my opinion. We successfully engaged a difficult, high-risk population, and we facilitated a team-based care model with suboptimal staffing. The project used simple interventions with no cost to the facility. The project was individualized to the SCP at our health department and used no extra staff. SCP champions are more than capable of training new staff members to this testing process without any management involvement, and the project can be easily spread to any other health department strength exchange program to increase their testing and right care services of HIV and hepatitis. It's my hope that comprehensive preventive health care will be available in all SCPs. Next steps for the study would be to implement the project in outreach programs and to spread to all SCPs in Kentucky for standardization of HIV and hepatitis care processes. Further study would include the addition of other preventative health services and exchange programs like vaccines and other screenings for high-risk populations. My big learn from implementing this project is that resistance to continual change is the greatest barrier to growth, and effective team engagement is the key to quality improvement success. This project was 100% team driven. If it wasn't for the team, none of this would have happened. Here are my references. And does anyone have any questions?
Good job. You were at 16 minutes and 56 seconds.
Awesome.
I do have 2 things.
Okay.
To suggest. On your rationale slide, the first time that you introduce QI, I would probably say quality improvement.
Okay, gotcha.
And then on your analysis slide, and maybe I missed it because I was trying to make notes too. Did you discuss how you analyzed the data? Like, she suggested to me to go to the Ogren book and like I analyzed it to see if there was like a special cause variation. Was what I was doing making the change, or was there something else that was impacting that and that kind of thing? How in depth did you go in your analysis?
Not. I don't really know. Like, I didn't have any trends or runs or shifts or any of that. All of my data, it was all improved, but it was all very variable on a day-to-day basis. So when I looked at that stuff, I couldn't find anything that I felt like was important enough to mention because it wasn't present. Like, I was like, why do I need to explain what a run is and what a shift is when they weren't there? It's just taking up time.
Right. So I had the same issue, but she suggested explaining that. So I just went through and kind of briefly said, this is what a shift and a trend, or I don't even remember, a run. I'm just kind of, and then like none of this was identified in this project, which meant that it was common cause variation, like the overall, how the whole process is in the clinic. So nothing specifically that I did made a huge impact to cause us to have a shift or a run or anything like that.
Okay, I got you. Yeah, that makes sense. I'll try to see if I can put together one sentence to sum that up.
Yeah.
I can include it if I can remember.
I'll send you an email.
Okay. Thank you.
But otherwise, I thought you did great.
So you think it'll be passing? It'll be okay?
I thought you were wonderful. I mean, I understood everything that you were explaining, and I was really impressed with your results, and your flow was good. You weren't rushed. So
Okay.
I thought it was great.
I thought you did great, Wendy. I like the way you like broke up. Like I love the big learn at the end of the. I haven't seen that with anyone yet. That the ones that I've seen. I really like the big learn and the way you broke up each slide with like the main titles. It was really easy to understand.
Thank you, girls, so much. I appreciate it.
You're welcome. All right, Stephanie, are you ready?
Okay, my best college to Sundays is, but
Right.
I'll probably be making a lot of notes. But here we go. No. I'm already making it. Do you have it?
Yes.
Okay, good. Okay, here we go.
Oh, hang on. Let me get my timer ready. Sorry.
Okay. Just let me know.
Okay, I'm ready whenever you are.
Okay. So I want to thank everyone for coming to my DNP presentation titled Improving Patient-Centered Sexual Health Care for Adolescents Attending an Urban High School Utilizing the SBIRT Framework. This is a picture of my team that helped me with the project. My team consisted of nursing staff as well as social workers and psychologists, and they were a very hardworking, committed team, and the success of this project is due in large part to their hard work, and I really want to thank them for that. For the national problem, although adolescents only account for 25% of the sexually active population in the United States, they account for over half of the 20 million cases of sexually transmitted infections that are diagnosed annually in the United States. It's further estimated that 1 in 4 adolescent females will have a sexually transmitted infection. And in 2016, the total cost for testing and treatment was $16 billion per year for treating and testing for STIs. Although teen pregnancy rates have been decreasing over the last several years, it is still a significant issue, with the United States having one of the highest teen pregnancy rates among Western industrialized countries. And there's a large health disparity that exists for minority adolescents in rates of STIs and teen pregnancies. So for the local problem, this bar graph depicts the sexually transmitted infection incidents at West High School over 3 years. And as you can see, the incidence of STIs doubled, more than doubled actually, between 2015 and 2017. And this pie chart represents the racial incidence of STIs for students here at West High. And as you can see, our African-American students bear the burden of the majority of STIs, with 54% of the incidents being in African-American students, and they only actually make up about 14% of our student population. Chart audits that were done indicated that 20% of the time informal health screens were performed, but they were not standardized screens, and they were mostly problem-driven from problem visits. It also, chart audits also indicated that 70% of the time, a key component of sexual health risk assessment was omitted, and that was determined by the guidelines of the 5 Ps sexual health assessment by the CDC that looks at partners, practices, pregnancy prevention, past STIs. So depending on this study that you're looking at, it's about 15 to 50% of adolescents reporting that they've received some kind of preventive screening in the last year. So adolescents aren't receiving regularly schedule preventive screening. And with this decrease in preventive screening, they're concurrently participating in a lot of high-risk behaviors that can lead to significant morbidity and mortality. And in relation to sexual health, it can lead to chronic pain, infection, infertility, and certain types of cancers. So the American Medical Association and the Academy of Pediatrics recommends that teens be screened for health risks at least yearly. And they have created, the AMA has created the guidelines for adolescent preventive services, and the AAP has created the Bright Futures guidelines to standardize the screening process. And these were used to create the universal health screen that I used in the project. For the rationale, this project used SBIRT, or Screening, Brief Intervention, and Referral to Treatment Framework. SBIRT is an evidence-based, patient-centered process that utilizes universal screening, motivational interviewing, and goal setting as a brief intervention, and if necessary, referral to further treatment. I also used patient-centered care as a rationale, and that's one of the Institute of Medicine's standard of improvement for quality health care. They define it as providing care that is respectful of and responsive to individual patient preferences, needs, and values. And this project promoted patient-centered care by using youth-friendly techniques and making sure that the adolescents that were seen were aware of their, informed and aware of their sexual health care rights and confidentiality rights. So the aim of this quality improvement project was to increase the rate of screening and completed right care by 50% over a 90-day period for students presenting to the West High Health Office for care. West High is a urban high school located in Madison, Wisconsin, with about, give or take, 2,200 students. The students are adolescents from diverse socioeconomic and racial backgrounds, with about 34% of students at or below the poverty level. The health office has a high patient volume with 80 to 100 students seen per day. 43% of these visits are by African American students, 30% are by white students, and approximately 14% of visits are by Latino students. The great majority of the visits are problem focused, as I've said before. So the impetus for this project was to move towards more preventive screening and care, especially in the area of sexual health. And for the process of quality improvement, I used 4 plan, do, study, or PDSA cycles, and each cycle had small tests of change with 4 core interventions, and data was collected and placed on run charts that we'll talk about later in the presentation. These are my core interventions. They consisted of team engagement, patient engagement, screening, and case management log to track on right care. Team engagement was promoted by biweekly team QI meetings where clarification of goals occurred and also education occurred. Patient and student engagement was promoted by focusing on patient-centered techniques such as shared decision aids, youth-friendly techniques, a patient-centered curriculum from Planned Parenthood. And for screening, the health risk screen was a universal health risk screen that had small alterations during this project to optimize student understanding and inclusion. And lastly, the case management log that tracked and drove right care, and the right care included further sexual health screening with the 5 Ps, education and counseling regarding barrier methods, STI and STIs and contraception. And these went through the case management log went through some small changes, the most successful one being the addition of a triage column, which made it possible for students to be seen at a later date during non-academic times. So there was both qualitative data and quantitative data collected in this project. The qualitative data included student and staff interviews It included field notes that were daily record of daily happenings and insights regarding the project, and also the health risk screen contained an open-ended question that achieved qualitative data. For the quantitative data, aggregate data was compiled for all the core interventions and placed on run charts, and Likert scales were used to assess team engagement as well as student empowerment related to their sexual health care. So these are the chart of the measures. There were both process measures and outcome measures. The process measures were the utilization rate of the screen, the surveys, and the case management log, as well as the effectiveness of team meetings. And for the outcome measures, they included scores on the team engagement and student empowerment scales or surveys, the number of positive screens, and the percentage of right care components received. For the analysis, data was plotted on run charts every 3 days and analyzed. Run charts allow for data to be seen in a time sequence and can demonstrate if improvement is taking place as a result of the interventions or the small tests of change. Run charts can also be analyzed to look for shifts or trends that can indicate a change is taking place and is not just a random occurrence. These are the results. As you can see, I'm happy to report that we surpassed all our goals in this project. Student empowerment was increased significantly to a median of 94%. The aim, which is at the bottom, the second one from the bottom, which was the average of percentage of completed screens and the percentage of completed right care, realized a median of 79%. And the balancing measure, which was the level of or percentage of grade decline as out of class time increased with screening and right care, actually stayed at 0%. So that was positive. So these are a few of my run charts. This is my run chart demonstrating the student empowerment and the large increase that occurred in cycle PDSA 2 is when we really focused on informing them of their confidentiality and healthcare rights. And it, as you can see, it took a huge jump from January 25th to February 4th and stayed kind of consistently above the goal as we made sure that all the students were aware of their confidentiality rights and also their sexual health care rights. This is the graph for team, or the run chart, sorry, for team engagement. And started off in PDSA 1 with a kickoff meeting, which increased engagement, but there was still some question about exactly what was expected of the team members. And that's when in PDSA 2, warm handoffs were talked about and initiated for the social workers and psychologists doing warm handoff with students that they wanted referred to the nurse directly, that give everyone a concrete goal until the team engagement and commitment increased to 100% and stayed there for the remainder of the project, and which we also in meetings included some simulations and also a discussion of a article regarding the sexual health outcomes of students with mental health issues. And so that really reinvigorated the referrals also and the commitment and kept it high. Now this is a graph of the student report of sexual behavior, so the positive screens. It varied from day to day, but we ended up with a median of 45%, which is in alignment with the national average of 40%. So I really got the sense and feel that kids were being honest and really open about their sexual activity. So the aim of this project was achieved. 183 students were screened and 97 of them received right care. So school health services can be expanded to include problem and preventive care. There's 42 million adolescents that attend schools on a daily basis, and school health offices are a perfect environment to bridge the gaps of preventive care. I also feel that the strength of this project was that we reached a wide range of students. I saw, equal mix of genders, of ethnic backgrounds, of grade levels. So reached a wide range of students. And also another great strength was my team participation and the commitment to the team of the team members. As we've discussed before, an increase in student empowerment did correlate with friendly techniques, which involve, informing them of their rights and also using open, non-judgmental communication with adolescents. Team engagement was optimized by good communication, and the importance of an interdisciplinary team was proven in this project. Their teams are dealing with a lot of complex issues in our society, and it takes a comprehensive care with an interdisciplinary team with professionals with different expertise to provide that care. There's also, I found that one of the big findings was there's ability to promote culture change in the high school health offices, that initially kids were kind of apprehensive about what this new process was, but they really did enjoy it and they really did want the information. And I feel like that it could be, it was really important to promote preventive care with adolescents who aren't getting a lot of it. So limitations for this, one of the limitations to generalizability of this project would be the access to nursing services. So here in in the Madison School District, we have advanced practice nurses at most of our 5 high schools, but maybe smaller districts don't have the level of nursing services we do, so it won't be as generalizable maybe to other districts. There also would be, to stay in this project, there would be a need to make some changes in the workflow to free up the advanced practice nurses to have more time for preventive care. And another would be access to an interdisciplinary team. Again, smaller districts might not have the strength and skills of the team that I had. So for conclusion, I think the screening and education counseling process can be expanded to additional environments at my school and also other schools in the district. And my hopes are that it will be expanded to a school-based health center. Adolescents can and were easily engaged in preventive health care and really did want the knowledge regarding their sexual and reproductive health. Data from this project also is going to inform the development of future health services to be offered in the district, and it's definitely being used to design a condom availability program that will be starting here next fall. And I also feel like a big thing for this project would be to potentially address the health disparities that exist between our minority students, to improve access to care and to provide more education for a stronger knowledge of how to take care of themselves and access health services. And my last slide is a picture of 3 of my graduating seniors that gave me permission to share their pictures. They participated in the project and gave me feedback. And I just put this picture up here because I believe adolescents are one of society's most important resources, and it's important that they're learn to be empowered to advocate for themselves, and given the knowledge to make healthy decisions to become healthy and happy, productive adults. These are my references. That's it.
Okay. So you were at 17 minutes and 38 seconds. I really liked your graphs in the beginning because that was very impressive to see, especially the percentage of your African American students compared to the size of your population. So I thought that really had a big bang. one thing that I noticed on your rationale slide, and this is just because I'm weird, but there's just a space, an extra space after your hyphen where you have goal, and then the next one I wrote INST, so I'm not sure what was
Okay.
on, but there's like an extra space there, and the others are not. So, and then is there any way you can make your run charts bigger so you can see your annotations, or make your annotations bold or something? Because I couldn't read those.
Okay.
I thought you did a really good job. I followed your entire project, and it was very easy to understand and see what you all did. So I thought that was great. The one negative that I would say is you say a lot.
Yeah.
But I think, because you know this, if you would just keep going over it and over and over it, I think you'll cut that out because you knew what you were saying.
Yeah.
It was just like a nervous, because I do the same thing.
It was like my second time going through it. So yeah.
Yeah. So really, you did. Yeah, you did awesome. Then if this is just your second time, yeah, you've got this.
Yeah.
Okay. Great, guys.
Yeah, I thought you did excellent, and what a great project, and it's so underserved. Like you know, kids in high school, none of this stuff is really big on nurse practitioners. You know what I'm saying? Like they don't really look into all that when high school. It's always once they get out of high school, it's more geared towards college age kids.
Yeah.
So that's amazing. Great.
Well, thanks.
But you guys did awesome, and I know you're gonna just nail your presentations and be perfect. So, Wendy, I'm going to try to make yours in the morning, but it's right as I'm getting to work. So,
I completely understand. Well, I had yours in my calendar. I had accepted. I was ready to go, and then this one started throwing up everywhere. So I had to tend to the baby.
I completely understand.
Well, good luck, Wendy. You're going to be
Thank
great.
you too, Stephanie. Julie, I'm so proud of you. I hate that I missed it, but I'm going to watch your recording as soon as I get them uploaded and ready to go.
Thank you. You guys are going to do awesome. I'm going to stop the recording now, and I will